Hi, good afternoon, everyone, and welcome to the webinar. The topic for today is on birth equity, and we're talking specifically about birth equity in the suburbs. So my name is Martine Hackett, and I'm an associate professor in the Master of Public Health program at Hofstra. And welcome to this presentation. Thanks so much for your interest in this topic. And the purpose for me to be able to share this information with you is to first of all let you know about what the sort of issues are as it relates to infant and maternal mortality, but also to really kind of give you some specifics around the data of what is happening right in Nassau County, where Hofstra is located. And I'm also going to sort of frame this as the way that these data look in a national scale. And finally, I will also be talking about what are some best practices or ways to be able to address this issue, as well as some things that are happening right here in Nassau County. So without any further ado, let's get started. So I start by sort of, again, framing this issue on a national level. Some of you may have heard about the issue of maternal mortality, that specifically Black maternal mortality, that has been in the news quite a bit for the last year or so. Serena Williams, when she had her baby over a year ago, was someone who was in a situation that was life-threatening. She had a history of blood clots in her lungs, and right after she gave birth, she was, telling the physicians that this is something that she felt was happening, and she was denied or not really believed in terms of that level of care. And so the issue is that these are problems that are happening all around the country, and in fact, Serena Williams' example tells us that the issue of maternal and infant mortality for Black women is something that affects us across our socioeconomic status. Because who's more famous than Beyonce? And she is also someone who suffered during her pregnancy with her twins preeclampsia. And preeclampsia, or also known as toxemia, is something that in interviews she has said that she was not aware that she was at risk for, and in fact it necessitated her to have an emergency C-section. So again, here we're talking about healthy, well-educated, and high-income Black women who are still suffering from the risks around their pregnancies. Also, too, someone who might be a little less well known, but who sadly died as a result of the issues around maternal mortality, is Erica Gardner, who was an activist here in New York. And she died within a couple of months after giving birth, in part because of a pre-existing heart condition. And so it really, the idea of maternal mortality is something that we are looking at as a way to understand not just, why is this happening and to whom is it happening to, but really, how does this sort of identify the larger issues that are at play when it comes to looking at healthcare for Black women in the United States? Because it turns out that in the United States, our maternal mortality rate is increasing, whereas all in other developed countries around the world, that same maternal mortality rate is decreasing. And so this is, as this article suggests, defying a global trend. Why is this happening? Why is it that we see in the United States that maternal mortality is increasing, where in other countries it's decreasing? We also know that the United States does not rank first, second, or even third when it comes to newborn survival. In fact, the United States ranks 22nd among all countries in the world in terms of newborns being able to survive their first birthday. And so this is not something that we expect or anticipate or really should tolerate here in the United States. The other thing that we need to look at if we see these issues around the health disparities or differences when it comes by race, ethnicity, and we zoom in a little bit closer in Nassau County, which is a suburban county right outside of New York City, where Hofstra is located, we see that, for instance, the percentage of births with early prenatal care, 91% of white mothers had that, only 74% of Black mothers had that. When it comes to premature births before 37 weeks, 9.8% of white mothers had premature births, as compared to 14.4% of Black women in Nassau County during that same time period. This is also connected to the percentage of low birth weight births, which are higher among Blacks in Nassau County than whites. And so, again, when we start to see the differences in Nassau County, they are reflecting the differences that we see nationally. But again, the bigger question is what is happening and why? And if we look even more specifically at the infant mortality rate in Nassau County by race ethnicity, we see something, again, that's surprising, not expected, and frankly, not acceptable. We see that the infant mortality rate, so infant mortality rate is the death of an infant under 1 year, in Nassau County is 9 infants dying for every 1,000 that are born. I should say 9 Black infants dying for every 1,000 that are born, compared to 2.2 infants that are white in Nassau County during the same time period, and 3 Hispanic infants that are born during that same time period in terms of the infant deaths. And so, again, this disparity or difference that we see in an infant mortality rate by race ethnicity sadly also reflects what we see nationally. But one of the things, again, that's not expected in a suburban area like Nassau County is that the Black infant mortality rate is higher here than it is in New York City. And so, again, the New York City is a place that has people coming from all over the world, but yet we also see that their Black infant mortality rate is lower than it is in Nassau County. One thing that's important to know about an infant mortality rate, and again, that's the death of an infant under 1 year, is that the infant mortality rate in public health is often called one of the most sensitive indicators for the health of populations. And the reason is because infants are the most vulnerable members of any society. They can't take care of themselves. And so when you see a place or a country or a county where the infant mortality rate is high, that should tell you something is happening, that the most vulnerable members of that community or society are not being cared for and not being protected. And so, again, when we see a high rate of infant mortality, Black infant mortality in Nassau County, that indicates to us that there are larger issues at play. And then when we look at the maternal mortality rate in Nassau County, we also see something that's not expected. In Nassau County, the maternal mortality rate from 2013 to 2015 were 28 women dying for every 100,000. During that same time period, we see that rate is higher than 4 out of 5 of the boroughs in New York City, only surpassed by the Bronx. And so, again, the maternal mortality rate is defined as the death of a woman within 40 days after giving birth. And so this can happen during the childbirth experience, immediately after, and after she is discharged and at home. And so, again, when we see a place that has a high maternal mortality rate, we often, first of all, are not thinking about the United States, and certainly not thinking about a suburban community like Nassau County. But again, it tells us that something is not happening well in the larger system to be able to protect the women who are in a very vulnerable state. I also want to point out to you some other health indicators that have to do with maternal health in Nassau County that also will help paint a picture in terms of what is happening here. When we look at the ratio of Medicaid births to non-Medicaid births, and so Medicaid is a insurance that is for people who are below a certain income. And the ratio is the number who have Medicaid paying for their births versus those who don't, who have private insurance. It turns out that Nassau County is in the 4th quartile, or the bottom of that ratio. And that's actually higher than it is in all of New York City. And so what does that tell us? That tells us something that we maybe didn't expect, that there are more of these Medicaid births in Nassau County than there are overall in New York City. And again, that's not something that we would expect. We also see that the percentage of pregnant women who are participating in the Women, Infant, and Children program, which is, again, a program that one needs to qualify for based on income. The percentage of those women who have gestational diabetes, and so gestational diabetes is a condition, a metabolic condition that often happens just during pregnancy. So you don't have to be a diabetic to have gestational diabetes. And what we see is that in Nassau County is also in the fourth quartile or the bottom of the percentage of pregnant women with WIC who have gestational diabetes. And again, that's also worse than all of New York City. And again, that's in the fourth quartile in the state. So again, that's not something that we would expect for those of us who live or even have an idea of what life is like in Long Island and Nassau County, that our outcomes would be worse than they are in New York City for pregnant women with gestational diabetes. When we look, and so this is a map of Nassau County, and this map is also identifying the rate of infant deaths by zip code. And so the darker blue areas represent the areas with the highest rates of the infant mortality rate. And so what we can see here is that, there seems to be like a geographic clustering of the infant deaths and where they are occurring. And in fact, when we look at this geographic clustering of where these infant deaths are occurring, and if we also look at this map, these are the areas that have where people have had late or no prenatal care, we see that there are many of the similar neighborhoods. And for those of you who are not from Nassau County, and maybe even if you are from Nassau County, you can't necessarily pick out some of these neighborhoods on the map, I want to tell you that the areas, the zip codes that have the highest rates of both infant mortality and late or no prenatal care are overwhelmingly areas that are that are African American. And so I think that one of the things we have to also recognize is that when we're asking ourselves, why is it that in Nassau County we have these rates that are higher for maternal and infant mortality? Part of it has to do, of course, with the individual behaviors of the women during pregnancy. But I want to suggest that even though that's necessary, that's not a sufficient answer to be able to explain why we see such differences. And I want to suggest that some of the differences are actually right here on this map. One of the things that we know about Nassau County is that it's one of the most racially segregated areas of the United States. And there is a connection to be made between where people live and their health outcomes. And so the fact that we start to see these outcomes or these poor health outcomes related to places where people live, and that the places where people live are the more racially segregated neighborhoods, we start to recognize that this goes beyond just individual behaviors. Let's zoom in even a little closer to two adjacent zip codes. And this also, I would suggest, helps to bring this point home that geography and place matters. Here we have two zip codes. One is Hempstead, and that is 11550. And in Hempstead, there were 4 infant deaths per 1,000. In that same time period, in zip code 11530, which is Garden City, there were 0 infant deaths during that same time. And so, again, did all the unhealthy people say, let me move to Hempstead? And all the healthy people said, let me move to Garden City? I want to suggest that certainly income and socioeconomic status have something to do with this, but also the idea of the conditions that people are living in also contribute to these difference in outcomes. These are 2 other zip codes that are adjacent to each other right in Nassau County. And so if we think about that bigger map that I showed a minute ago of Nassau County, Uniondale and Hempstead are some of those areas where we had the highest rates of infant mortality and late or no prenatal care. Here are, again, East Meadow and Uniondale, and we see that East Meadow had 5 infant deaths per 1,000, and during the same time period in East Meadow, there were the number was half as much, that there were 2.6 infant deaths per 1,000. And again, with understanding that in Nassau County, we're talking about extreme sort of racial segregation, it shouldn't be too much of a surprise to know that Uniondale is a majority minority community, and East Meadow is not a majority it's a majority white community. And so again, we start to see some of these differences and start to understand that when we're looking to sort of understand why these conditions are happening in the suburbs, we also have to understand what are the reasons why we have higher infant mortality rate and maternal mortality rate, not just in the zip codes and not just in Nassau County, but in the United States. And again, why we start to see that these differences are play out in Black women's bodies, but that they also are informed by these larger social conditions. Here, finally, is another side-by-side comparison. Roosevelt, again, another majority minority community, and Merrick, where we see the difference is quite stark, that the infant mortality rate in Roosevelt were 8.8 infant deaths per 1,000 as compared to 1 infant death per 1,000 in Merrick. And so again, this plays out over and over again in many of the zip codes where we have the high infant mortality rates and the sort of adjacent zip codes where they're quite low. And I should just add, for those of you who are not from Nassau County, to get from one end of Roosevelt to the other, to one end of Merrick, we're not talking about driving for hours. These are really a distance of just a couple of miles. So going back to the idea of the timing of when we start to see what are called maternal mortality deaths, but are also can be called pregnancy-related deaths, we start to recognize that when they occur is a very big indicator in terms of what are the reasons behind them. It turns out that when we look back retrospectively at maternal deaths, and I want to add that these data are coming from maternal mortality review committees in 9 states that were done across the United States. And from their review, they found that 38% of these maternal deaths occurred while women were pregnant, 45% occurred within the 42 days, and 18% occurred within between 43 days and 1 year. And so the reasons are different. The maternal deaths that occurred during pregnancy could have to do with pre-existing conditions like cardiac conditions or asthma or other conditions that women might have had before pregnancy. The 45% within 42 days can be anything from hemorrhage that happens right after giving birth, or pulmonary embolism, or blood clot, which is what Serena Williams had, up into other kinds of issues that might happen as a result of the pregnancy. And when we go out all the way out to 1 year, we are now also talking about additional causes of maternal death that actually include everything from suicide to intimate partner violence. And so again, once we start to really connect these ideas of these maternal deaths that are related to pregnancy, we start to recognize that there are many conditions that are affecting women that aren't just due to their lifestyles or their behaviors, but also are connected to the conditions in which they live and in the way that they're being cared for. So this slide has a lot of information on it, but it's all good. The information here really sort of helps to explain, again, this question that as we start to look at these data, and we start to see these differences on a national level, we start to see these differences on a county level, we start to see these differences in maternal and infant deaths among Black women and Black infants in Nassau County. The question, of course, is why? Why is this happening, and what can be done about it? It turns out that, again, when we talk about the idea of the risks for these higher maternal and infant mortality rates among African Americans, that, again, these exposures to these risk factors have to do with these these larger factors, including poverty, low socioeconomic status, limited access to prenatal care, and, again, the physical and mental health of women before pregnancy. Even though those are very significant risk factors, as I have already discussed, they're not sufficient to be able to explain the magnitude of the differences that we are seeing on a national, county, and zip code wide level. In fact, when we start to look at other data and research, we start to recognize that in part, the idea that there are differences between the racial ethnic groups also have to do with the idea of not just your socioeconomic status, but also how you're treated. And so the idea that that African American women who initiate prenatal care in the first trimester still had higher rates of infant mortality than non-Hispanic white women who had late or no prenatal care tells us something. The fact that in a recent study by the New York City Department of Health said that African American women with normal weight were still at higher risk of dying during the perinatal period than non-African American women who were obese. In addition to this, we know that Black women who are college educated have a higher risk of dying due to maternal mortality than less than high school educated white women. So again, education, socioeconomic status, BMI, these are not going to be, passes to be able to get you out of these conditions that we start to see that race clearly is playing a very significant factor in, again, the not only the conditions, but how you're being treated in the healthcare setting. So, one of the ways to be able to think about why this is happening, and again, if it can't only be explained by lifestyle behaviors, by socioeconomic status, by healthcare access, another thing to consider is something called the life course perspective. And so, what does this say? This says that social and economic forces affect African American women's development across the lifespan. What does that mean? That means from the time a woman is born, time as a baby, right, as a female infant. She's exposed to social and economic factors that actually take a toll on her body over the course of her life. These chronic exposures to stress and the stressors that are related to them, to the living conditions, for instance, that has a physical manifestation in creating a higher allostatic load and burden on the body systems. So again, what this really means is that the connection between the conditions that you're living in, how you're being treated, how the body reacts to that by the production of a stress hormone like cortisol, that production of that stress hormone can lead to a suppression of your immune system and to increasing your risk of infections. And so here's where we start to be able to connect the dots, to be able to say the where you live and the way that you're being treated and the across your life course can actually have a way of being explained as to why that is presenting itself as an infant death or a death due to childbirth. And so even if African American and non-Hispanic women report similar levels of stress during their pregnancies, because of this life course perspective, because of the toll that these stresses and the conditions that you're being treated take on you from the time that you were a small girl, African American women's increased exposure to stress throughout their lifetime increases that allostatic load, which increases their risk of maternal and infant mortality. So what does that say? That says that when Black women become pregnant, they're not just entering into this unscathed. They're entering into the condition of being pregnant with carrying with them the life course influence of the stressors and the ways that stress has taken a toll on their bodies. And so this connects to how we think about public health as it relates to many different health outcomes. It turns out that when we think about health outcomes, and in particular when we think about disparities or differences in health outcomes, that our health behaviors like our diet, how much physical activity we have, whether or not we smoke, is absolutely significant, but insufficient in being able to explain those differences entirely. In fact, health behaviors account for about 30% of the explanation in terms of what contributes to your health outcomes. Access to care is something also that people often will say, let's make people have more, health insurance and, able to get that prenatal care. And no one's saying that that's bad. That's actually an extremely important and significant factor. However, it's not a silver bullet. Clinical care, it turns out, not only the access to care, but also the quality of the care also contribute to about 20% of your overall health outcomes. So when we think about this, your behaviors, your lifestyle, access to care, the two things that most people sort of, default to when they think about why health outcomes are worse in one group than the other. Turns out that those two things together account for about half. What is the other half? Well, social and economic conditions, so education, employment, community safety. Research will tell us that that accounts for about 40% of our health outcomes or the reasons why we see these differences. Add to that the physical environment of where you live, everything from air and water quality to the quality of your housing. That adds the additional 10%. So here we start to see that again, individual behaviors and access to care it accounts for about half of the differences, or that account for about half of the reason behind our health outcomes on a population level, and that our socioeconomic and physical environment contribute to about the other half. So again, we're talking about this on a population level, which is important to know about public health, right? We are interested in individuals, but we're really looking at populations as a whole. And populations can be a zip code, it can be a county, it could be a state. But really, what we're thinking about is that when we think about what are the reasons behind our the differences in health outcomes, we have to take into consideration not just individual behaviors and access to care. We also have to take into consideration the socioeconomic conditions and the physical environment. So, how does that apply to what we can see to address the issues around Black maternal and infant mortality in Nassau County? So one of the things I want to suggest is we need to look at this from a systematic level, and to be able to sort of understand that when we are talking about these health outcomes, we're talking also too about, again, the way women are treated. So part of the way women are treated is just really information and being informed about what some of the potential risks may be. Informing women after childbirth about the warning signs for hemorrhage, embolism, and infection, especially those with pre-existing condition, sounds like something that's really straightforward, sounds like something that's pretty easy. But if I told you that that is not happening now, and it's certainly not happening in Nassau County, would you believe me? And hopefully you would, because it's true. And so the idea of just even starting with this, right, to be able to inform women about that. And again, what research also tells us is that, once a woman has delivered the baby, guess where all the attention goes? To the baby, not to the woman who has just gone through this very extreme physical condition. And so often women are discharged from after labor and delivery, are discharged after a couple of days without being told what are the warning signs for hemorrhage, without being told what are the warning signs for embolism. And guess what? If they're not looking for them, you're not going to be able to find them. And so the idea that this is something that is, again, an occurrence and a common occurrence for maternal mortality needs to be more, awareness of it needs to be more present as women are being discharged from the hospital. We also know that service integration for women and infants is also an important factor. So what does this mean? This means the idea of women being navigated through the system to be able to say, within a healthcare system, if you have a pre-existing condition, what are some things that you might want to watch out for? If you are perhaps at risk for housing conditions and the quality of your housing once you are discharged, what are some things that perhaps can be done about that? And so the idea that this integration of service between women and infants also suggests that when you're pregnant, you are treated by an obstetrician gynecologist. But as soon as you deliver that baby, the focus again is on the infant and the pediatrician. Most women, in fact, only 40% of women, 40% of women do not go to their 6-week checkup to go back to their obstetrician. So what we're talking about is this idea of integrated care is to be able to say that as women bring their children, their infants to their pediatrician office 1 week, 2 weeks, 1 month after, and people, by the way, do that very well. That's like in over 90% of infants are brought to their follow-up well child visits. Can we integrate those services so that mothers are also cared for as well? And so the idea from a hospital systems perspective is also to think about treating women of color in a respectful and culturally relevant care, to be able to say that we understand what are some of those life course conditions that they have been exposed to, and to be able to be cognizant and appreciative of what it is that they will be continuing to go through. Another best practice when it comes to the health delivery system goes back to what I had mentioned earlier about the way that Black women are treated in the healthcare delivery system. So several studies have indicated this. And again, I want to suggest that if you talk to just about any, let's say, all right, let me just say, if you talk to let's say 5 Black women who have given birth within the last 10 years and ask them about the quality of their experience, I'm feel fairly confident that at least one of them will be able to express to you that she was treated with disrespect, that there wasn't a lack of there wasn't attention to her concerns, and that this is something that again that is sadly quite common when we see care for Black women during the birthing period. High levels of stress, this disrespect, and the racism during pregnancy and during birth actually can be associated with some of these poor outcomes that we see, and not only increased maternal morbidity and mortality for women, but also to help to contribute to the higher risk of infant deaths as well. So this idea of best practices then is also thinking about what are the words and the ways that physicians and nurses are dealing with their Black patients. It turns out that researchers found that when they look at these maternal deaths and what were classified as near deaths to understand what went wrong, one thing that they noted is what is called delay and deny. And so delay and deny is a woman saying, I don't feel right. I feel really, something is going on. I feel that, really feverish. I feel like I'm bleeding a lot. I feel that I am, I feel pressure in my lungs. The idea of those conditions, which, by the way, are all warning signs of hemorrhage and embolism, that those are things that are often delayed and denied, like, oh, you just had a baby. Oh, you're very tired because of what you've just been through. And so sadly, the more that those symptoms are denied and delayed, the worse that they get. And so this failure to recognize a woman's distress signals, to listen to women, goes back to the first slide that I showed about what Serena Williams mentioned, and also sadly something that is quite common for women during the childbirth period, that their symptoms are not appreciated and certainly not acknowledged for the possible severity that they might have, and that this, again, this delay and deny can lead to worsening of conditions, and sadly can also lead to maternal deaths. And so, again, going back to this idea of best practices, research also will tell us that in the states in the United States that have more support for midwives have better birth outcomes. And so the idea of midwives who are as sort of contrasted with an obstetrician gynecologist who is a medical doctor. A midwife is often a nurse who is trained in women care and in childbirth and delivery. The idea that a midwife practices, the way that she practices, is inherently different from the way that obstetricians will. A midwife is, during your prenatal period, during your prenatal visit, is assigned to be with you and to talk to you, to ask you how you're doing. It's a more holistic sense of care. And also midwives are trained during the birth period to also be responsive to the mothers as well. And so it turns out that states that allow midwives more scope of practice and to have the ability to do their practice without physician supervision, I should say not supervision, but often in many states, their midwives are restricted by the permissions and that they have with hospitals and with clinicians. That states that have more support for those midwives have better birth outcomes. I think the takeaway here is that sometimes this level of clinical interventions don't always benefit women during birth. Of course, we know that cesarean sections and other interventions are crucial for saving the lives of many mothers and infants. However, one of the suggestions this research tells us is that that level of medical intervention perhaps does not benefit everyone, and so that the assessment needs to be made to say how much intervention is too much, and in fact, recognizing that most women are healthy during births, and most of those births are not necessary, don't need emergency interventions. So when it comes to other best practices within the healthcare system, we can also introduce and standardize protocols that are patient safety bundles that give guidelines and best practices, and to ensure that there's this consistent care across hospitals, clinics, and other private providers so that they are aware of what the conditions of preeclampsia, hemorrhage are, and the prevention of unnecessary cesarean sections. So again, recognizing that just because you have a hammer, not everything looks like a nail, that we need to be able to not only apply the tools as it is appropriate for each individual birth, but that clinicians also need to be prepared and aware of what are the conditions that might happen that are unanticipated, but that also are at high risk for maternal mortality. This flyer that you see here is something that is a suggestion of one of the things that can be done to help increase the education when it comes to the warning signs after birth. So this very simple flyer was created by obstetric nurses, and the suggestion is to distribute it there, and this is being distributed in some hospitals, but certainly in Nassau County, this is not the standard of care. And so even just making people aware of what those symptoms are and what to do about it, and to let other family members know about them as well, allows us to sort of, again, make people anticipate what are the possible conditions that can quickly go wrong. When it goes coming back to Nassau County, I just want to sort of also identify a couple of areas that can use improvement. In Nassau County, and this is an example of the community health assessment that was done that's done every few years by the Nassau County Department of Health. And I want to suggest, even though the data I showed you earlier were of the differences in those health outcomes by zip codes in Nassau County, and the maternal mortality rate is higher in Nassau County than it is in every borough except the Bronx in New York City, that there's no mention of these issues in this health assessment, and that there's certainly, sadly, no programs that specifically address maternal and infant mortality disparities in Nassau County as well. And so just this idea of the data not being available, not being visible, is also, I want to suggest, a best practice, because certainly if things aren't being seen, we are not able to do and to interact when it comes to do something about it. So this also is a theme to be able to think about making injustice visible. We need to be able to see where these data are. We need to be able to understand who's being affected, and we need to be able to understand what can be done about it. Successful public health programs include those called Nurse Family Partnership, which is a national program, and Centering Pregnancy, which is a group prenatal care model. These are systems and programs that are built on the idea of providing culturally relevant care, peer-to-peer learning, and establishing social support, social and emotional support for women during pregnancy and after. And so when it comes to best practices, we have to recognize that we have to have a more holistic approach, and that to prenatal care and to care after pregnancy, and that this is something that, again, I want to suggest is not the norm in terms of what we see being practiced in Nassau County, and this is a way that we can see of improving our health outcomes. I also want to kind of give a shout out to an organization that I am associated with called Birth Justice Warriors that was started last year in Nassau County. And Birth Justice Warriors was created to specifically respond to these high rates of Black maternal and infant mortality in Nassau County. So Birth Justice Warriors looks to make these data visible, to let more people know about what's going on, and also to provide that peer-to-peer support, to provide to work with clinical practices so that they provide more culturally appropriate and respectful care, and also to advocate on a policy level as well to create changes in the support of women throughout pregnancy and after. And so I sort of want to end here by talking about Black Maternal Health Week. And so I don't know if you knew, but we are right in the middle of Black Maternal Health Week 2019. And so Black Maternal Health Week was created just last year, actually, to be able to understand and address that this issue, this national issue of high Black maternal mortality, is not something that's acceptable and something that needs to be addressed. The theme for this year is called Decolonizing Data, which says that we need to accurately assess women's health outcomes, the quality of care for Black women, and also that we need to understand and to raise up the scholarship around and the research around maternal health. And so, again, here in Nassau County, we're looking to be able to do this by making injustice visible, by expanding this information that of what is happening here in Nassau County, and also to be able to say what are the ways that we can address this from a larger systematic issue, recognizing that when it comes to maternal and infant mortality, individual behaviors is a necessary but not sufficient way of being able to explain why these differences exist. And so we need to be able to address this on a larger systematic basis where the root of the problem lies. So I thank you for your time today, and I hope that this was useful to you, and or at least interesting. And I'm happy to be able to, if you have additional questions, please feel free to contact me. And this is me on Twitter. I'm at Public Healthy, and also this is Birth Justice Warriors contact information as well. So thank you so much for your time, and not sure if there are going to be any questions, but I think you can type in questions if there are on the side under this chat area that's on the left-hand side of your screen. So I'm open for questions if there are any, and if not, believe me, I can keep talking, but I would prefer not to and just let the information sort of speak for itself at this point. Okay, and so if there are no other questions, I thank you so much for your time, and I hope this is something that at least made you aware that these are conditions that that maybe you knew nothing about before. But I want to suggest that that's part of the problem. Part of the problem is that we are in the midst of an issue that is not getting addressed the way that it should. And yes, in answer to the question, this webinar will be made available on the MPH website. Thank you so much for asking.